Today we're going to discuss infertility. I think this saying is so telling of what women go through. What comes so naturally for many should not be such a hardship for millions of others. And when you consider how we try so hard not to become pregnant when it's not the right time, and then we finally are ready and try to conceive, it's cruel that women actually find out that it can be extremely difficult. So, the definition of infertility is the inability to conceive. But for women less than 35, they have to be trying for at least 1 year before we will label them as infertile. If a woman is 35 or greater, we only give them a 6 month period of time because the genetic risks go up. And we know that fertility decreases as age increases. Women who have a history of irregular menses are also in the catch basket of infertility because we never know when they ovulate. So the women who have polycystic ovary syndrome, they would be in that category. So 6% of women who are in that window of when we should be able to conceive between 15 and 44 actually experience infertility. And this affects 1.5 million women. Just stop for a minute and read this caption because infertility really is a loss. It's a loss of a dream. And it is a cycle of hope, despair, as they go through these menstrual cycles month after month. Oh, good, I got my period. Oh, good, it looks like I'm ovulating. Okay, let's have sex. And then, oh, hope, fingers crossed. And then the period starts. And then there's despair. So there are risk factors that point towards the infertility. If there's a history of endometriosis or a history of PID, things that can cause scarring of the fallopian tubes, the fimbria, where everything is matted down, because there's a certain peristaltic wave once the egg is released from the ovary, and those fimbria are out there like little fingers trying to capture it. Well, when we have endometriosis or we have scarring from PID, then they're not able to move freely. Patients who have a history of chronic pelvic pain and it's unexplained, well, they may have a lot of scarring that's going on inside the pelvis. Because remember, chlamydia is a silent infection, and so women can go around with chlamydia and have a mild form of PID that goes untreated, but it has destroyed the pelvic structures. Patients who have a history of recurrent miscarriages, they don't have an anatomic cause of their infertility. They may have an incompatibility between the genetic makeup of the male and the female partners. So when you look at the picture on the right, ovulatory causes make up about a third of the reason why people can't conceive, and it's equal to those who have some type of an obstruction of the tube. And so women who have tubal obstruction, if and when they do get pregnant, what should we be on alert for? Did you say ectopic pregnancy? I thought that's what you were going to say. So 20% of infertile women have a history of endometriosis, and then there's 10% where we have no idea. All we know is they can't conceive. Now the men do contribute to this picture, and the risk factors for them is that they have some type of an anatomic problem. But there are some men who actually have sperm producing capabilities that are diminished. So they can have a varicocele, which is the fluid that's within the scrotal sac. They may have had a history of an undescended testicle that has rendered them infertile. Use of hot tubs, because you're just frying up those little sperm and they don't want to be moving or they're dead. So semen disorders account for a lot of the infertility. And so when we look at the clinical evaluation, we start with the semen analysis. It's very easy to do. Male just has to ejaculate into a cup and bring it to us within about an hour. And we look at it underneath the microscope, and we're looking for the number of sperm, uh, the motility of the sperm, and we're also looking at the morphology of the sperm. Are we seeing some who have double heads? Are we seeing some that only have very, very tiny heads? Those are ones that are not going to be able to penetrate through that egg. We have the woman start out with a basal body temperature. So she gets up in the morning. Oh, she doesn't get up. We're doing this before she gets out of the bed with a special thermometer, and she takes her temperature every day. And what we're looking to see is the rise in temperature that accompanies ovulation. So the first half of the cycle, the temperature in the morning is in the 97 range, and then once they're about to pop that egg, we'll see the spike up to 98, and then it stays up all the way through the luteal phase. The blood analysis includes a TSH, a blood count, FSH, LH, prolactin, and estradiol. So the hormones, from the pituitary gland to the thyroid gland to the ovaries, that axis is important, and all three of them have to be functioning together in order for true ovulation to occur. We look at the CBC to see if there is something else that might be going on. So particularly we're looking at anemias, and then of course we can have blood cancers, but we're just looking at the overall health of the woman. So after we do the semen analysis and we do the BBT, which is the basal body temperature, we'll do a post-coital test. So the couple have intercourse, and then she comes in within about 6 hours. I used to like to have them come in within 2. And what we do is we aspirate the contents that are in the posterior vaginal vault. We put it on a slide, and we're looking to see what has the cervical mucus from the female done to the semen that has been deposited into the vagina. And because we can have what we call hostile cervical mucus, where the sperm is encountering it and it can be killing it or making them decrease their motility and things like that. So if we see that this is abnormal, then this couple is a candidate for intrauterine insemination, where we're going to bypass the mucus that's coming out of the cervix. In addition, we are going to do a day 23 progesterone level to see how good was that ovulation. We have her come in for pelvic ultrasounds, and we'll do a transvaginal ultrasound to watch follicular development. So we'll have them come in starting at about day 11, and we look at the size of the follicle. So when you look at the picture up on in the top right, you can see that she has a pretty good follicle there. The number 2, that is the 20 millimeters, that one's getting ready to rupture. And so if we see her on day 11, 12, 14, 16, and these follicles never even got to the point of being 20 millimeters, we know that that's not a good ovulation. She may be a candidate for Clomid or Pergonal to stimulate the development of the follicles. If we're suspicious of things like PID scarring or endometriosis, we have a variety of other diagnostic tests. So we'll start with a hysterosalpingogram, where they shoot dye up in through the cervix and we watch it flow. It should go into the uterus, through the tubes, and out the fimbria, and it spills into the pelvis. Some of the doctors will give the patient a prescription for doxycycline, because you get a sort of a sterile inflammation, but it's painful. And just in case there might be a little bit of a chlamydia in there or something, that's why they choose the doxycycline, because it'll kill it. A hysteroscopy, they're actually putting a little camera up there, and they're looking for things like polyps. And I have the next slide, you're going to see some of the things that we can see. And then last but not least is a diagnostic laparoscopy that's done on an outpatient basis. So they're going in, doing a laparoscopy, and they're taking a look around. And this may be the first time a patient is ever diagnosed with endometriosis. So these are some interesting pictures of what we do. So the top left is the what the normal uterus looks like. Okay, so this is the hysterosalpingogram. So the dye is shot through the cervix, and she has a beautiful uterus, and then it flows out through the tubes, which are very, look how thin they are. So when you think about ectopic pregnancy, this is what that egg is going through, and it's very small. And then you see the spill into the pelvis. So this is a healthy looking female anatomy. Now look at the one next to it. Do you see how tortuous and enlarged those tubes are? And this is what we call a hydrosalpinx. And so these are very dilated. These are not functioning well. They are not having that normal peristaltic activity when that egg is trying to go into the uterus. And then the one on the upper far right, you can see that we shot the dye in, it went into the uterus, and it stopped. And so this woman has no fallopian tube function whatsoever. So how can an egg ever get in there? So what do you think that this patient is going to need in order to conceive? We'll talk about that in the next lecture. On the bottom left is what we're going to see when we have an endometrial polyp. And an endometrial polyp, why this can interfere with conception is the egg, the fertilized egg, if it tries to embed itself on a polyp, that's not a good place for it to be able to grow. And so when we do an ultrasound, or on this picture on the far left, they did a hysterosalpingo or a hysterosonogram, and we can see it on the salpingogram. We see this thing that's just in there, and it's like, is this a fibroid or what is it? So they'll go ahead and do a hysteroscopy, and they can see this polyp, and they will remove it at the same time. They just reach in, they cut it off, it's going to heal up, and then voila, she might get pregnant. And then the last two are pretty interesting too, is that we can see in the middle one that there's a lot of adhesions on the right adnexa. So we shoot the dye in, and it's just finding these little areas for it to lay on, because there's some part that's open, some part that's closed, other parts that are open, other parts closed. And so the dye is just sitting there, and it's sitting on top of scar tissue. So once again, this is an unhealthy tube. And then last but not least is a bicornuate uterus. And so what this means is that within the uterus itself, so when we palpate it, doing a bimanual exam, it feels normal. However, inside it has two horns. In fact, I just had a patient yesterday in the office who said, yeah, I have PCO, but I also have a bicornuate uterus. What will happen here is her tubes look fine, but it depends on what is on the inside of that uterus. Is there going to be a membrane that separates it? Is it wide open? But it can have interference with implantation. And I have had patients where they implanted on one side but had a fully developed endometrium on the other side, and then they come in, oh my God, I have a positive pregnancy test, I'm so excited, and then they call and say, oh, I'm bleeding. Well, why are they bleeding? Well, we didn't know they had a bicornuate uterus, and they are actually shedding the lining in that other horn. So it's an interesting phenomenon. They can get pregnant, they can carry it to term, and that other horn just collapses as the baby grows. So this ends part one of infertility.